we're going to kind of focus on today is the role of rheumatologists in the multidisciplinary care of patients with autoimmune encephalitis. And kind of thinking, starting with when rheumatologists may be involved. And I think that's challenging because there's a lot of variability across the country, depending on primarily the availability of neuroimmunologists. And there are more neuroimmunologists in the adult world than there are in the pediatric world. And I think partly for that reason, pediatric rheumatologists have been more involved in the care of children with autoimmune encephalitis and other autoimmune inflammatory brain diseases, really over the past 10 years or so, partly in the reflection of that lack of neuroimmunology training in many of our pediatric neurologists, and that is an area that's really growing and exciting, but it's allowed us to kind of get into this space. So much of what I'll say today pertains more to pediatric rheumatologists potentially than adult rheumatologists, but I think there's a lot we can learn from this experience. So common reasons that rheumatologists are involved in care, classically they're asked to come consult to rule out a rheumatic disease such as neuropsychiatric lupus or things like that. And they are also at times asked to help with decisions around immunosuppressant treatment, ongoing management and long-term monitoring for patients. In particular, in pediatric rheumatology, there are many places in the country where pediatric rheumatologists are asked to take primary ownership of patients with autoimmune encephalitis, and we'll talk about that a little bit more here in the next few slides. So we did a survey in 2015 of pediatric rheumatologists asking them what their involvement was in the care of children with autoimmune encephalitis. There were at the time about 300 pediatric rheumatologists in North America, so the US and Canada, excuse me, that portion of North America. So it was a fairly decent response rate. Of the respondents, 74% responded that they evaluated and treated children with autoimmune encephalitis. And 20% of those who responded stated that their institution they were the primary service who took care of children with autoimmune encephalitis. When we looked at what the role was of the different pediatric rheumatologists involved in AE care, we found that all of them pretty much were involved in ruling out rheumatic disease. But approximately 60% were involved in actually the initial management to help decide if this was an autoimmune encephalitis in the first place. And then, of course, often asked to participate in the decisions around treatment recommendations. Our next question was about pediatric rheumatologists' comfort and challenges in taking care of children with autoimmune encephalitis. And we asked of those who felt they had significant challenges, where they saw those challenges. And 64%, or about 60% of the respondents had significant challenges in caring for children with autoimmune encephalitis. I think you'll be able to see my pointer here. The most common issues they had was feeling they did not have adequate training during their fellowship, otherwise to treat those children, and just how sick these children were from both a neurologic and psychiatric disease state. There were also significant findings in that 40% of pediatric rheumatologists found it was difficult to collaborate with neurologists. And when we dove into this a little bit more, we found this kind of spanned some pediatric rheumatologists wanting to be more involved, but being at an institution where they either had a robust neuroimmunology program where they were not felt to be really needed in the care of children. But more significant number of pediatric rheumatologists who were being asked to really take on the primary management of these patients and not feeling that they had the skill set to do that and the support. And probably one of the most dramatic examples of that was when a pediatric rheumatologist came up to me after a talk and asked how I decide when to taper AEDs. And I said, I let the neurologist decide that. You know, sometimes we don't taper them at the same time we taper immunotherapy. And she's like, oh no, at my institution, as soon as it's diagnosed as an autoimmune encephalitis, they sign off on the case and it's only followed by rheumatology. So it really just kind of highlighted the spectrum that I've seen across the country in terms of the role that pediatric rheumatologists are playing. In the adult rheumatology world, where there are certainly more neuroimmunologists, their involvement in the rheumatologists that I've spoken to has not been as robust as the pediatric rheumatologists. And I think that we have primarily adult neurologists on this call. So you may have a very different experience. But I think it's taught us some really interesting lessons about how we need to think about the degree of interest in having this collaboration, both from the neurology perspective as well as the rheumatology perspective, and how we can really meet in the middle to figure out the times when it really is appropriate for rheumatologists to be involved, or when we're really just another cook in the kitchen that's not really contributing to care. And so when we think about that, I think about the timing of involving rheumatologists, and there's a little bit of a Goldilocks issue here, where if we get called a little too late, sometimes that can make it really challenging if we're trying to then figure out if this is a primary rheumatic or other autoimmune process. These are classically patients who didn't respond well to initial therapy, and people are kind of rethinking what the diagnosis was. And this can make it challenging if patients have already received steroids and IVIG, as those treatments can alter our ability to do workups for some rheumatic diseases. It's also a challenge for rheumatologists to come in at times when they're only seeing the sickest of patients or the atypical cases, to really have a good sense about how to conceptualize the severe forms of an autoimmune encephalitis or other primary neurologic entity versus when they should be having red flags for more of a primary rheumatic or potential rheumatic disease. Likewise, the conflict of consulting us too early is that we may be getting consults on a bunch of patients where we don't really contribute anything. They have a more straightforward neuroimmunology diagnosis, and that may result in unnecessary testing in some cases. And so I think trying to find that just right is challenging. And again, we'll circle back to this theme of your local institution and colleagues around you helping figure out what that collaboration should look like. And in my experience, both working here at Duke and kind of developing this collaborative model, which I've been really blessed to have fantastic colleagues in neurology and psychiatry that were willing to go on this journey with us, is really evaluating the experience and the confidence of your providers, both on your neurology colleagues and their comfort with neuroimmunology, as well as your rheumatology colleagues and their comfort with neurology or neuroinflammatory diseases, and figuring out where the strengths and weaknesses of each other are and where you have potential to collaborate. And in that process, you're also able to figure out the ability or the availability and willingness of each other to collaborate. Really, where are the lines that we feel in our institution we really have figured out, and where is there the potential for that overlap and collaboration? And then I think also working on figuring out kind of some red flag kind of things in terms of things that you want. If neurology is going to be the primary service, evaluating, which it is in most places, including my institution, what are some things that you want those residents or fellows or providers to be thinking about when they're doing their standard history, to kind of layer in when they're thinking about a neuroinflammatory or autoimmune process? That could be reasons that you would think about consulting rheumatology earlier rather than later in the course. And sometimes even having a few screening rheumatology labs that don't add a ton of cost to the care, serve really just as a screening tool to help you decide when it's worthwhile to engage a rheumatologist at that stage or not. It's a pretty broad differential of rheumatic diseases that can cause pretty acute onset neuropsychiatric symptoms that can look a lot like an autoimmune encephalitis. Neuropsychiatric lupus is certainly the most common encountered entity that both rheumatologists are seeking neurologist support for, and neurologists may question, especially in young women, developing new onset psychiatric or neurologic symptoms. But we have a broad spectrum of vasculitides that can do this, including primary CNS vasculitis, especially the small vessel or angiographic negative vasculitis that can look very much like an autoimmune encephalitis with pretty diffuse manifestations. And then we have the dreaded neurobushettes and neurosarcoid, and I call them dreaded because they can be very challenging to diagnose at times, particularly when patients are presenting initially with neurologic manifestations of these conditions. And though the official diagnosis for both neurobushettes and neurosarcoid depends on systemic manifestations that would support the primary diagnosis of Behçet's or sarcoid, we do have significant data that shows some patients will present initially with those neurologic manifestations, and they may evolve over time. And we certainly had a case of that in our institution with a young man who presented encephalopathic with seizures and MRI changes. He eventually went on to get a brain biopsy that was concerning for vasculitis. And as his dad was tapering the steroids because he didn't like his son on steroids, he developed oral and genital ulcers classic of Behçet's, had a biopsy of the skin lesions that confirmed that diagnosis. But that was only after about 5 months after his initial presentation with recurrent neurologic disease. So those cases can be really challenging and definitely worthy of some collaborative effort. And then antiphospholipid syndrome can cause certainly an encephalopathy, often movement disorders such as chorea can be seen in that group too. So just having some of these conditions in the back of your mind, if you're a neurologist, to kind of think about signs of systemic inflammation, thinking about rashes, the classic joint pain and things like that, of course, but other organ involvement that would kind of point you toward wanting to engage a rheumatologist early in the course. And then really where we spend a lot of our time is in the treatments. So many rheumatologists will sign off after this stage. They've gone through the initial evaluation. They do not think this is a rheumatic disease, and they sign off at that point, which is great. Others are going to be continue to be involved or will not be primarily involved until we get to the treatment stages. So even after someone has been diagnosed with primary autoimmune encephalitis, rheumatologists are often brought in to help with deciding about escalation of immunotherapy primarily. There are times when we're asked to consult about IVIG or steroids, and our neurologists are really thoughtful about recognizing the fact that once they give those medications, it can alter our workup. So sometimes it's just a curbside, and sometimes it's official consult, and other times they feel confident with what the disease is and they move forward with those first line therapies, which is great. But really kind of having a plan in place is as best you can at your institution about when medications are going to be initiated. And then there's some significant back and forth sometimes at our institution about kind of when to escalate and how to decide to escalate. And that's a dance that we've done over the years, and we really have a good system in place now. But it's not always easy and neat when you're first developing these collaborations. And so I think having that open communication, direct communication is really helpful. There are some differences in the kind of understanding of timing of when after you started a disease modifying agent, when you should expect it to start working and when you would say it's failed. And I'll talk about that a little bit as we go through some of these specific medications. And then also some opportunities for discussions around escalation of medications. So when we're thinking about the treatment of autoimmune encephalitis, I think we want to be thinking about, what our targets of immunotherapy are. And I think of them in three broad categories. We're trying to remove the antibody. We do that through plasma exchange, which directly removes antibodies, as well as IVIG. And I think there was a question in Dr. Najjar's talk about all the different ways that IVIG works. And there are, over a dozen different mechanisms that are thought to explain in part how IVIG helps decrease inflammation, in particular for antibody-mediated diseases. But one mechanism is increasing the clearance of antibodies, in particular autoantibodies. We also are trying to stop the production of antibodies, autoantibodies in particular, and this is where we have the more targeted B-cell therapies and newer plasma cell therapies. But steroids work on really all parts of the immune system and decrease that inflammatory response and cell proliferation and inflammatory response to it. And then we're going to talk more about these particular medications as we kind of go through the next few slides. And then the last, which I think is really equally important, is we need to decrease the inflammatory response to the antibodies. So we can have local effects, complement activation, T-cell mediated injury that can occur related to these antibodies. And certain antibodies are more likely to trigger that complement activated and T-cell activated immunity that can be more destructive, where other antibodies such as NMDA may work more by the involution of the receptors, and there may be less destruction, which may in part explain why some patients can have such dramatic recoveries with some forms of autoimmune encephalitis, even when they're severely ill, compared to others that tend to be a little more refractory to immunotherapy. And those are really helpful things to think about, what that antibody is, what type of immune response you have to that antibody when it's known, it's not always known, to help you think about which medications you want to use, which part of the immune system you want to target, and the urgency of escalation. I think those things come into play when we're thinking about that. So I think, as Dr. Pediatric said, like NMO, free destructive antibody in many cases, GAD antibodies in GAD-associated diseases can be a more destructive antibody where you may have less reversibility and may want to treat more aggressively really right out of the gate. So pretty much all of the medications are going to work on decreasing that inflammatory response to some degree. Steroids certainly do in decreasing complement activation and recruitment of other cells. IVIG has numerous anti-inflammatory effects. It inhibits the complement cascade. It stimulates regulatory T cells, which I think Dr. Najjar mentioned earlier on in his talk. It neutralizes autoantibodies. I think someone had asked a question about when you give IVIG, does it have anti-neuronal antibodies effects? There are neutralizing effects to autoantibodies that have to do with the variable region, so anti-idiotypic antibodies that help clear those autoantibodies, even if they're not directly against an NMDA or a particular target per se. And then they reduce some of the cytokines that are involved in inflammation. So, IVIG, there's a reason everybody loves it. It works in lots of different ways and mechanisms to decrease the immune response. And then some of our more targeted anti-cytokine therapies like IL-6 inhibition with tocilizumab, as well as mycophenolic acid, which has significant effects both on cell-based immune responses as well as cytokine production. So I thought we'd spend just one slide looking at the immune system. Hopefully you all remember this from your med school days. I'm sure in very detailed memory, but in terms of your B cell lineage and the stimulation of B cells by antigens, and then this necessary co-stimulation by T cells to really activate B cells to start producing antibodies. And those activated B cells can go on to become short-lived plasma cells, and these still have CD20 expressed on them, which we'll talk about when we talk about rituximab. But I assume many of you are familiar with rituximab use in autoimmune encephalitis, and so it can target short-lived plasma cells. They have not lost their CD20 markers, and similarly can target plasma blasts. So as you're going through this differentiation into these different antibody-producing cells, and these little ones here with these antibodies, these little Y-shaped antibodies are all antibody-producing cells. The rituximab can work against your activated B cells, it can work against short-lived plasma cells, and it works against plasma blasts. This is similar to most of the other immunosuppressant medicines that we think about that really are working on cell division. And so these cells are actively dividing, and that's unlike plasma cells, like long-lived plasma cells. So those have lost their CD20 and CD19, and they have stopped dividing. And so these cells are not susceptible to things like Cytoxan, to rituximab, to many of our medications that really target cell division and replication. And so this is where some of the newer agents that proteasome inhibitors are really being helpful, and we'll talk about those at the end of this talk. So when we're thinking about how the antibody kind of production cycle works from initial B cells through plasma cells, we recognize that the effect of the medications that we're using, some will work quickly and some will not work quickly, depending on which part of that immune response we're trying to target. So if we're targeting removal of antibody with something like plasmapheresis, you may see some variable response. One of the challenges with plasma exchange or plasmapheresis is you're not decreasing necessarily antibody production, you're just removing it. And so if you haven't removed the trigger that's kind of producing that ongoing antibody production, you may not necessarily have a dramatic impact on the disease. And so this is where we find, and I think pretty much most people do this, you want to be doing plasma exchange, and then in addition to steroids, IVIG, or other things that you're hoping are going to be decreasing that ongoing antibody production. Steroids and IVIG tend to work fairly quickly if you're going to see a response to them. Not everyone has a response that you'll see, but many patients can have almost a near immediate response with IVIG for a variety of immune-mediated conditions. Certainly autoimmune encephalitis is a much more variable response, with some people having a fairly quick response within a couple of weeks, noticing notable improvement. It may not be full recovery by any means. It pretty much never is, but you may say, okay, yeah, I feel like my steroids and IVIG are moving the needle or improving. And there is evidence that giving these kind of stacked monthly doses that you'll see that ongoing improvement, and that's all that some patients require. Certainly for NMDA encephalitis, many people are using rituximab. There's ongoing debate right now about if that should be used out of the gate for all patients with NMDA encephalitis or only in those who are not showing a robust, I like to use that term, robust response to their first-line immunotherapy with either plasma exchange, IVIG, and or steroids. Rituximab works by depleting those B cells. And so as we talked about, it's going to be depleting the B cells, your plasma blasts, and your short-lived plasma cells. But it's not affecting your long-lived plasma cells that are really the big antibody producers for many patients with autoimmune diseases. And so depending, then there's some, at least some theories about treating early and aggressively, that you may be able to get to that plasmablast stage before true plasma cells have been produced. There's other situations where it seems to not really be time dependent, and I think that's part of that immune response we don't have a great understanding of. And so I think that in part explains some of our fast responders to rituximab and our slow responders. To rituximab, we've seen some patients who will start to improve within 2 to 4 weeks, but the usual expected time to see improvement after rituximab is usually 4 to 8 weeks. And that is the case in most rheumatic diseases as well. When we're looking at antibody-mediated diseases, such as encephalitis, when we're using it various components for lupus. And so I think that's one area where there's often been questions or calls that I receive from outside institutions where they will say, well, we gave rituximab and we're not seeing any improvement. And I'll say, well, how long ago did you give rituximab? Well, we gave it 3 weeks ago and we're not seeing any improvement yet. And we would say that's pretty early to see improvement. And we wouldn't say that the rituximab has failed, that rituximab had failed to respond to rituximab. We would say that we haven't really given it enough time. Now, certainly when patients are really sick, sometimes we need to think about layering medications on. But in general, my perspective and those of my rheumatology colleagues I've spoken with is if we're going to give a medication, especially rituximab, which has definitely its fair share of potential side effects, we want to give it a chance to work before we kind of escalate to other therapies. It also makes it difficult to know if you layer in another therapy 4 weeks into your dose of rituximab, was it the delayed effect of the rituximab starting to work, or is it really the other medication that you used, which complicates then how you decide about long-term management. In general, if we're not seeing any improvement in the 3 to 4 month window after rituximab, then we would consider adding other agents. And I think in really sick patients in that 2 to 3 month window, and other patients in the 3 to 4 month window. And there's a lot of discussion about this. There's no hard science or really trials to help us decide this. As someone had mentioned in a previous question, we can certainly see an uptick in symptoms as you approach your next dose of any of these medications. That can just show that there is an ongoing self-perpetuating autoimmune process that we haven't really aborted at that point, and that is an indicator in our mind, in my mind as a rheumatologist, that there's an ongoing process that's going to need either a prolonged treatment to try to, over time, impact this process, or that you're really going to need to escalate immunotherapy because you really haven't gotten to the heart of what's driving this process. Other kind of just time to respond things, because I think this does come up a lot. Again, almost all the medications outside of IVIG, steroids, and plasma exchange are going to take time to work. And while patients may not respond to those first-line therapies, when they do, you can sometimes see a pretty quick response. But most of these other medications are really going to be on the order of weeks to months. Cyclophosphamide, the general onset of seeing real improvement is 1 to 2 months. You will see depletion of your white cells very quickly, but the downstream effect that the cytoxin has on altering immune cells and altering antibody production takes more time than that. And so it's usually not a direct correlation with when you need or your white count with when you start to see improvement. MMF, it's kind of disrupting cell division again. And so that is going to be a little bit longer time. Usually, again, we're seeing something in the 1 to 2 months of start that we're going to start to see improvement. And then tocilizumab, an IL-6 inhibitor, it's a cytokine inhibitor. And this has a potential for a little faster onset because it's not only working on the immune cells directly and decreasing replication and recruitment into inflamed tissues, but it also has some direct effects on the cytokine effects on cells and driving antibody production that can work a little quicker in some patients. And so we have noticed in our practice that we will sometimes see improvement within 2 weeks of starting this medication. And it's very common that we're seeing improvement by 4 weeks in patients who are going to respond. And I think similar to what the published data is, we found in our experience that if patients haven't shown an improvement by 3 months, it's unlikely that they're going to, and we haven't continued it after that point. When we look at monitoring, with rituximab, which is the most commonly used, so I thought we spent a little more time on this one. We do follow CD19 or CD20 counts. We do it starting around 4 to 5 months after dosing, because there are patients, and this may be more relevant in pediatrics. We have noticed in our practice that younger children tend to repopulate earlier, but there's also evidence that people with a higher body surface area often have earlier repopulation too, that may be a dosing effect. And so we start checking that around 4 to 5 months so that we can determine if patients are repopulating early. People can repopulate anywhere between, they never deplete, which almost everyone does deplete, but there are a few patients who don't, really up to years after rituximab dosing before they repopulate. But most patients will start to repopulate by a year. And in our experience, most starting by 6 months, or starting around 6 to 9 months, we'll start to see some degree of repopulation. And so many people are doing the regular 6-month dosing now. I think this was described in encephalitis, also a common protocol in neuromyelitis optica. And so we have that practice in our group as well. But there are no trials or randomized controlled trials to tell us, first of all, when to initiate rituximab, let alone the monitoring and maintenance dosing of it for long-term use. But we do use this as a way to help us think about when to redose patients if they need it sooner than 6 months. The other available tests now are anti-rituximab antibodies. So if you have patients who are repopulating really early, it's helpful to think about getting those because if they have anti-rituximab antibodies, they will clear the rituximab more quickly and it will likely not be as efficacious. And it may be the time to think about adding or switching to a different agent. And then the last thing we think about is secondary hypogammaglobulinemia due to rituximab. And many of our patients are on concurrent IVIG and rituximab earlier in their course with tapering off IVIG. And so we do follow immunoglobulins on patients, usually starting 3 to 4 months after, just for the infection risk associated with that. And the other kind of thing I'm monitoring, in addition to the standard blood counts and other things that we do, for MMF, you can get levels of MMF. There are no therapeutic defined levels for autoimmune encephalitis or really most autoimmune diseases, but it can be a way to look and see if patients are adhering to the medication well. And there are some things like calcium that can inhibit absorption of MMF, and you can get a sense of how you're doing on your dosing in general terms. We have a lot of teenagers in our group, so we follow just to see if they're taking it or not. But the utility of that, I'll leave to you all. And then just in the last couple of minutes, we'll talk just a little bit about refractory disease. And this is what I'm defining as not responding to second-line therapy, which is rituximab and or Cytoxan. It should be noted, I think there are a few pediatric neurologists that had registered that some pediatricians, both rheumatologists and I think neurologists, are sometimes leaning toward earlier tocilizumab as opposed to Cytoxan, just because the toxicity of it is much less. And we have noticed some increased or faster onset of action. And so many pediatric rheumatologists are not using Cytoxan. There's been a couple of surveys both in the US and Europe that have demonstrated that pediatric providers, both neurologists and rheumatologists, are less likely to prescribe Cytoxan, more likely to use rituximab primarily than our adult colleagues. So tocilizumab is an IL-6 inhibitor, so it's blocking a cytokine. And there's several articles about using it in autoimmune encephalitis. I just provided the standard dosing. It's usually given every 4 weeks in critically ill patients. The rheumatologic data where this is used in arthritis and some autoinflammatory conditions can be used every 2 weeks and up to 12 milligrams per kilogram safely. And so we sometimes do use that more quote unquote rheumatology dosing in some patients. Tofacitinib has just recently been reported. This is a new favorite. I think there's a couple of rheumatologists on the call, so many of us are really enjoying having an oral biologic available. It's working in numerous conditions and primarily functions by blocking cytokine pathways for activating inflammatory processes. More to come on this, but this is just the first paper that I saw that came out recently looking at it in autoimmune encephalitis. In the last minute, we'll spend just talking a little bit about bortezomib. So this is a proteasome inhibitor that will help or works on plasma cells. So it does not depend on cell division. And it was initially used in multiple myeloma. And now is being used more in autoimmune diseases, including lupus. And the dosing has been adjusted a little bit. So this can be pretty toxic because you're basically killing plasma cells. So you're going to lose those antibodies that you have, those protective antibodies to vaccines and past infections. And so patients who are on this, it is recommended that they be on prophylaxis for PCP or PJPs, and HSV when they're on this medication. because you're going to lose your good antibodies along with your bad antibodies. Initial dosing was IV. There seems to be maybe less toxicity in terms of infection risks than others with the subcutaneous dosing, and I've seen 2 different reports of subcutaneous dosing. And it's given every 3 days for 4 doses and then a 10-day pause, and that's repeated in 21-day cycles. And people will get somewhere between 5 to 7 cycles is what's reported. And while it works very well for decreasing plasma cells and decreasing antibodies, you can detect true decreases in antibody levels. The problem with it is that it's short-lived, and these cells will start to regenerate within 10 days of stopping the proteasome inhibitors. And so this is a good initial therapy to, bring down antibody production, but it shows that we're still going to need combination therapy most likely, and people are still working out what that combination therapy looks like. I know CellCept has been discussed in this paper here, looking at it in lupus. So starting with bortezomib to decrease antibody production and layering in CellCept as kind of more of your maintenance medicine to try to prevent that resurgence of B cell activation and plasma cell production. So in conclusion, not everyone needs a rheumatologist, but some do, and kind of figuring out within your institution kind of what lanes people want and like to live in, and really where you need to meet in the middle, I think is really helpful. And to do that before you're at a crisis with a sick patient, I think is very helpful. And so starting those discussions with a rheumatologist who may be interested in the brain, or a neurologist who may be interested in autoimmune disease, and developing those partnerships, I think can be really rewarding. It's definitely the most rewarding part of my job, the ability to work with people in other fields really closely. I learn a ton. It's really fun, and I think we provide better care when we do it. Consider rheumatic diseases on your differential, and really be thoughtful about when to consult rheumatologists, depending on level of suspicion, because trying to diagnose these things when their patients are partially treated makes it a lot more difficult. And then thinking about really what parts of the immune system we're targeting. We have to respect that the immune system is a complicated system, and nothing's usually as easy as we think it should be or want it to be. And so needing to escalate to different therapies, being thoughtful about which parts of the immune system we're targeting, and the potential for needing multi-drug treatments, I think is really important. And with that, I'll take any questions.